Hi everyone, today we're going to talk about the most exciting development in gynecology, certainly in my career. Today we're going to talk about uterine transplantation. Joining me today are the UK pioneers of this operation, Professor Richard Smith, consultant gynecologic oncologist, and Miss Isabel Quiroga, consultant transplant and endocrine surgeon. Richard and Isabel, welcome. Thank you so much for joining me today.
Thank you. Great to be here.
Yeah, thank you.
So let's start from the basics. Can you explain to us what patient group you're targeting with this procedure?
So let's know that. Yeah. So we're looking to look after women who've got absolute uterine factor infertility. So these are women who've either been born without a uterus or who've had their uterus removed for one reason or another prior to having a family. So the majority of patients who've approached us have got Rokitansky-Kuster-Hauser syndrome. So they've been born without a uterus, they've got ovaries, they've got fallopian tubes, but there's no uterus and no cervix. And then we also have a much smaller group of women who've had their uteruses removed for cancer, or they've got Asherman's syndrome, they've got no lining to the uterus, or massive fibroids coupled with Asherman's, and therefore incapable of reproduction. So that's the patient group who've approached us.
Okay. So the largest patient group are patients with MRKH syndrome, as you mentioned. These are women who have been born without a uterus. And for those interested, I have done a video about that condition. You can get more information there. So we won't go into it in detail today, as we want to talk mainly about the operation. And Richard, can you give us an idea? So this is I guess, relatively new operation. How many transplants have been performed worldwide to date?
So worldwide, there's over 100 been done, and in excess of 50 babies born. A majority of those cases have been living donor, a minority deceased donor. So the procedure is in the very early stages, as we might want to expand on that, comparing it to kidney transplant in the past.
Yeah, so with all transplants, it always is so one that is the first, and then it does take a long time to develop the techniques to identify how to best manage the patient. So it does take a very, very long time, and I calculate that for most other organs, it has taken 10 to 15 years until the procedures are taken over or taken up by other maybe not skillful, but no, what am I trying to say? It's just it is difficult for everyone to take up a new procedure.
Yeah. Okay.
So that is very common. That the first transplant was done in 2014, successfully in 2014, and here we are, down 10 years down the line, and still very few transplants have been done all over the world.
But I guess with everything, it starts with a relatively small number and then it expands as the number of centers expands and the number of people who perform the operation expands. So, I mean, it's a real positive thing that 100 has been performed. That sounds like a landmark to me. Isabel, can you kind of enlighten us now? Just to remind you, this podcast is for patients and the public. So we try to avoid using complex medical terminology where as possible so that it remains as accessible to everyone as it can. Can you tell us in basic terms how a uterine transplant is performed?
Oh, that's very simple.
To talk about it simple as opposed to doing it, I bet that's not simple.
With any transplants, the one thing that one has to do is provide blood supply to the organ. So what we do is we join the vessels of the organ, the artery that brings the blood into the organ, and the veins that will take the blood back into the patient. So it's basically joining two arteries and two veins on both sides. And then, of course, or Richard has to anastomose, join the vagina that comes with the uterus to the patient's vagina. So it really is a minimum of 5 joints, 4 vessels, and 1 vagina.
Yeah.
What we're trying to do is provide as much blood supply and as better drainage to the organ as possible. So it's often that one needs to do more than just one vein on each side, and we do. Technically, it would be preferable to do as many as possible.
Okay. And are there any investigations needed beforehand? Well, I assume there are because it's such a complex procedure, or any conditions that need to be satisfied. So, like I told you, I have patients who have MRK syndrome in my clinics, who are very keen to have more information about what's involved in having a transplant. Um,
So
what
yeah,
would you tell them about what conditions need to be satisfied to say, yes, we can put you on our waiting list for a transplant?
so when the patients originally come to see us, the two principal sort of anatomical factors are one are their kidneys in the correct position.
Yeah.
So pelvic kidney, the kidney instead of being up here in the pelvis is a contraindication because there's no room to put the
No
uterus in.
space. Yeah.
And the other thing is no artificial vaginas. So people who've had artificially created vaginas, particularly out of pieces of colon or ileum, etc., are not. That's a preclusion for us. We want vaginas of a certain length, preferably 6 centimeters and above. And the recommendation is primarily for dilator therapy to achieve that in those women who aren't in that position. In addition to that, of course, these women, when they come to see us, they come to Charing Cross first to a gynae clinic, and then they go to Oxford thereafter. And there's psychology, they're assessed both from our side, and then there's MRIs done to assess vessels, and then there's psychological assessment, and then they go to Oxford and they see you and your team, and there's a lot more things being done there. And then that gets the patient potentially in the position to be listed. When we see the people originally, one of the questions is, are you coming with a living donor or are you looking to be in our deceased donor program? And a lot of people actually, when they first come, aren't sure about that. And sometimes they think they bring in a living donor and then they decide that that's actually not for them, and vice versa. So we've had quite a lot of people changing backwards and forwards.
Okay. So I didn't realize. So you have both a living and a deceased donor program. Oh, that's interesting. Okay. And that brings me.
Just the one thing, of course, we just need to make sure that the patient is healthy, they're in good general health,
Yeah.
with a normal renal function, because that's very important. Once that you start medication, that could be affected. The renal function can be significantly affected by our drugs, and if they had cancer, they need to have been cancer free for a minimum of 5 years. And we can go into a little bit more details of the reason why a bit later.
Okay.
It's been one of the sort of interesting things that to get in our program for transplant, you have to be a fit, healthy woman.
Yeah.
Whereas, of course, the patients Isabel usually looks after are having kidney transplants, pancreas transplants, and these are very, very unfit
Very
people.
ill people. Yeah.
So it's the people who've been ill and have been used to being patients, whereas the people who are coming to us actually have to be eligible, as Isabel just said, fit, healthy young women at the end of the day.
Okay. So two important points I just want to emphasize that you've made really clearly are that, one of the key pillars of management of MRKH syndrome is creation of a vagina. And, I always counsel my patients to, there's several choices. Vaginal dilation is usually the first choice in the UK. And I always counsel that you have to keep into consideration if you'd want to transplant in the future, consider carefully how we're going to create that vagina. So I'm glad that you have agreed. I've been telling the right thing all these years. And secondly, kidney is really important. So again, part of our usual workup when we see patients with MRK syndrome is a renal or kidney ultrasound scan to locate the kidneys, make sure they're in the right place, or to be aware of them wherever they are. But also kidney function, that's an important one that has to be assessed, and that has to be normal before they go along for a transplant. So that's important to know. Thank you. I'm learning by the minute here. And you talk about the donors, so there are two programs. Can you tell me how the donors are identified? Do patients have to identify their own donors, I imagine? Is that how it works?
Well, I can take that first one.
Yeah.
So, yeah, in terms of living donor, at the moment, it's mother to daughter or sister to sister
Okay.
are the two groupings that we're involved with. That may expand out at a future date because we've actually had hundreds of women volunteering to donate their uteruses to our
Wow,
programme
that's
in a
amazing.
completely altruistic fashion.
Yeah.
But that's potentially into the future. That's certainly not now. At the moment, it's mothers or sisters. So it is one of those. It's one of the lines in questioning in the clinic. And of course, there's an element of dependence on mother's age, and then there's also any sister clearly has had to have completed their family, not had an excessive number of caesarean sections, and fulfil various criteria. And then on the deceased donation side,
With any transplant, it's important obviously to have somebody that would be a donor. However, even if you have somebody, you might not be compatible with it. So first, the donor and the recipient have to be blood group compatible. That is essential. And the tissue compatibility means that they don't have to be identical, but the closer you are, the better. But what we are most interested in is to make sure that the patients don't already have preformed antibodies, or that they are already prone to rejection of that particular donor, of that particular tissue from the donor. So those are part of the test that we do before, and that applies to both the living and the deceased donor program. But from the disease side of things, again, once that we have a potential donor, the first thing that we will look at is that blood group first of all, followed by tissue type and the antibodies. And of course, for some women, it might be quite relevant the prior infections or some viral infections that are normally acquired during childhood. But if they have not had seen, or if they've not had that infection, but the donor has it, that might preclude the donation to go ahead, because primary infections, while you are immunosuppressed, once that you had your transplant, could be potentially very, very risky. So that's all the things that we consider while we have an offer.
Yeah, I mean, the two viruses specifically, cytomegalovirus and Epstein-Barr virus, is a huge advantage to have already had them if you're approaching us, because the majority of the donors tend to be positive.
Okay, and Isabel, can you talk a little bit more about the operation itself, which sounds really, really easy, plugging in arteries and veins, and then joining up the vagina.
That's Richard. I don't know anything about vaginas.
Okay, I'm pretty sure it's one of the most complicated operations going. Every operation has risks and complications, and often that is quite rightly a big factor in a decision-making process of whether I want to embark upon this operation, or whether actually I can think of other mechanisms such as surrogacy or adoption, for example, that are available, particularly in this sort of surgery that isn't life-saving, but it's elective and it's very much related to quality of life and reproductive ambitions, which is extremely important. Can you talk us through what the main complications, obviously you can't talk through every single thing, but things that merit mention today, what are the complications of this procedure? So there will be complications both for the donor, if it's a live donor, and the recipient. Yes? Can you just talk us through it?
So I think that for the live donor, probably Richard could talk better about the donor, if you want to.
Yeah, no, cool. So the procedure for living donation is very much like a modified radical hysterectomy, which we normally do for cervical cancer. And this is an important factor because a lot of people have Googled hysterectomy and they can see now laparoscopic procedure, robotic procedure, 1 maybe 2 nights in hospital. This is not a simple hysterectomy. So what we are removing is the uterus, the cervix, the fallopian tubes. We're not touching the ovaries, but we're then removing the uterine arteries and in a living donor, the internal iliac arteries, which are the big vessels that then feed down to feed both the uterus and the bladder. We are, in a living donor, retrieving vessels, which the veins are the veins that go back up towards the ovaries. In a deceased donor, we're also retrieving the internal iliac veins. And this is one of the whole things with living versus deceased. So for the living donor, there is implicit risk of all surgery, anesthesia, infection, bleeding, deep venous thrombosis, and other organ damage. Of course, in the deceased donation setting, there's no risk on that front, and the risk then will pass to Isabel just in a sec with respect to the recipient. So when we're counselling people for living donation, we go through all of those risks, and we're taking actually a very short cuff of vagina. So instead of a cervix cancer where we would take a 3 centimetre cuff, it is much shorter than that. So there's going to be no shortening of the vagina for the donor. The time in hospital, we're doing this through a surgical incision, which is horizontal, suprapubic, slightly larger than the standard one. And we're usually keeping people in hospital for 4 to 5 nights as a living donor. In terms of obviously once the uterus comes out, it's then recipient has their surgery, and I'll pass to Isabel to do that.
Yes. So I think when we talk about risk, we always talk about immediate risk at the time of surgery or soon after surgery. Yeah. And then you talk about the long-term risks associated with this procedure and with transplant. So when we're talking about the immediate risk at the operation, bleeding, of course, is one of the first that come to mind. We try to minimize that risk by having with us colleagues that we could circulate any bleeding and almost do like an auto transfusion if there is some significant bleed. Then we have.
Sorry, so that means the blood goes out and back into the patient. You're giving them back their own blood. Yeah.
Yes. So we also have maybe infections, and with any operation, you can have infection around the wound, or chest infection, water infection. That's not unusual. Or we could damage other structures. Again, I think that's less likely, but there's always a possibility of that. Now, the main risk with this novel technology, the novel transplant, is that this is it's an organ that these vessels are tiny, very, very delicate. And what happens often is that the blood supply is impaired or stops. And this is one of the big challenges that many other groups have had. They have a very high early failure rate. Failure as in the blood supply stops to the organ. And if that occurs, then of course the organ will have to be removed. Yeah. So those are and we don't want that. That is one of the things that we really fear. Therefore, we anticoagulate our patients. We give a lot of blood thinning medication to our patients in the post-operative period, and hence we might have a bit more risk of bleeding after the operation. But as I tell Richard all the time, the patients, we can manage bleeding. I don't mind bleedings. But relatively, of course, but if the organ thrombosis, there's nothing, if there's no blood flowing into the organ, then there's nothing else we can do, and it needs to be removed. So those are the early complications, if you like. Of course, many other things could happen, but those are the important things. Then we come on to the bit more longer term, and one is rejection, and that's when our own body will detect that this organ does not belong to us and starts fighting it. And to prevent rejection, what we need to do is to give patients medication to bring their immune system down. In a way, what we want is that our immune system to ignore this transplant. But the immune system is protecting us against infection and against cancer. And because we bring the immune system down, we are exposing patients to a higher risk of infection and cancer. And this infection risk brings us to what we were referring to before, these viral infections. And then the cancer risk, what we are aiming to do with this transplant is that we want to limit the amount of time that the transplant is in place.
Yeah.
So we only have a few number of years, hopefully 4 or 5 years of immunosuppression, of anti-rejection medication, and hence reduce the risk of potential cancer in the future. Obviously, the younger you are, the less likely you are to get cancer. But there are some cancers that are potentially quite serious and could affect even young people. So those are the main things. But the final risk is the risk of the medication itself. And the medication has some side effects. And one of them is that one of the drugs could affect the kidney function. Another one is they could affect diabetes. Patients can become diabetic, can reduce the bone marrow, so you are more prone to be anemic or to have very low defenses as well. And it could finally, sorry, the list is very long.
No.
And it could, it could give even hypertension. So all this that you as obstetricians, gynecologists know well, do have also could affect future pregnancy. So all this is very important when we are counseling our patients, and it's something that we discuss at length. All our efforts are trying to minimize those risks, but those are real. And but in my opinion, with good counseling, worth taking and close monitoring, worth taking for those that want to take them and they really wish to have them.
Yeah, so you say it's a long list, but it's really important because people view it maybe as it's an operation, but it's not just an operation. There's a lot around the operation that's really important, and there can be risks, for various things: the operation, the medication, etc., etc., etc. Richard, did you want to come in there?
Yeah, it was just as Isabel was talking, it just reminded me that one of the other things is that all of our patients are tested for living donors are tested for HPV, and we can't transplant the uterus with HPV, and the deceased donors also are tested for HPV. In the living donor setting, we have used antiviral agents to get rid of HPV and then potentially been able to go forward. But that's that obviously, if we transplanted with HPV, then there's much increased risk of cervical cancer.
Yeah. So HPV is the virus, human papillomavirus, which is causative of cervical cancer, cancer of the neck of the womb. So again, it's just trying to avoid the recipient getting something that they wouldn't ordinarily have if they hadn't had the transplant. And so you've said, Richard, that the donor will have a bikini incision, so across the lower tummy. And what incision does the recipient have, Isabel?
Oh, it's an up and down.
It's an up and
It
down.
is that in the middle. Yes, normally just above the umbilicals, the belly button.
Belly button, yeah. So
button.
I figured, so I just thought I'd clarify that.
Yes, yes.
So there are no surprises with the
Well, it's
dressing
just because it gives us a lot of flexibility, so you can just get better access and expand the incision if needed.
Yeah, as I always say, no one wants to struggle at an operation. You need access. It's as simple as that. Okay. So the patients who are coming along for this operation will be doing it with the eventual aim of carrying their own babies. Yeah, baby or babies. And can you just talk us through, because you've been, absolutely clear about the various stages, what happens, but can you kind of tie that together? So if I were a patient, say I had Rokitansky syndrome and I wanted to have a transplant in order to have a baby, carry a baby, then can you just talk us through briefly what the patient journey is like from beginning to end?
Okay, so they start by being referred to a clinic in Charing Cross, which is a uterine transplant clinic. And from there, that's the first assessment. They then go to Oxford, second assessment. They see psychologists, further assessment. Then, of course, there's the reviews after that. And then they have to have minimum of 5 pre-implantation genetic tested embryos in the freezer. So some people have done that before they get to us because they're thinking of going down a surrogacy route or going
Right.
down or transplant. They're not sure which way they're going to go, but those embryos have got to be created, and thereafter, if it's a living donor case, then we can set a potential date for that surgery after all the assessments have been done. If it's deceased donor, then they're listed. Do you want to talk through that a bit, Isabel?
Yeah, so they follow exactly the same pathway once that we've done all these investigations and gone through all the channels. But then they are exactly the same as if they were any other transplant. So a living donor had to go through a very exhaustive tests and discussions with an independent assessor, which is a professional that is employed by the Human Tissue Authority, that they need to ascertain that there's no coercion. They both know, both the donor and the recipient understand, and they know what they're getting themselves into. So that's the same with a kidney, a living donor kidney, or basically, or a liver. And then they have the transplant. If they're going for the disease, they are listed, they are discussed at a meeting with all the professionals. Is our listed NDT, so everybody agrees that this is it should go ahead or could go ahead, and the patients are listed, and they are listed and waiting in a national waiting list, which is actually national because there's nobody else doing it, but it's our waiting list. Waiting for that call and for that donor.
And then once you've had your transplant, you've got minimum of 6 months follow-up, which is intense and really important to say that. So we want patients to be living close to Oxford/London in the first month, and intensive follow-up through that time. Really important that they come to the transplant centre here in Oxford. That's a much more important part than our gynecological follow-up. And then a minimum of 6 months or further on, that's when embryo transfer can take place. And that, in fact, takes place at Lister Hospital in Chelsea, who supported this project from the get-go way back. And then once somebody's pregnant, the management moves over to Queen Charlotte's Hospital, collaborative with Oxford, obviously. And we have a multidisciplinary meeting, usually once a fortnight these days, which is to make sure we're all acting as a cohesive team, which we do, which is great.
Okay. And then
again, you get to have a cesarean section, and then you get to have a cesarean section, and then you have a choice. So at 6 months post delivery, you can have your womb out, and then you stop your immunosuppressive therapy, or you potentially can go on to have one more baby. And once you've had one more baby, 6 months after that, the womb needs to come out. So it's really our timeline, as Isabel referred to earlier, is we're looking for that womb not to be in for longer than 5 years. And that's to tie in with risks of cancer and infection.
Because I think that it's important to point out that a uterus has one function and one function only, which is to carry a child. And once that function is done, it is essential that the uterus is removed and that all the immunosuppression can be removed or can be stopped. And it's almost like the day that the uterus comes out, then you could stop taking all these drugs that are quite heavy guns.
Yeah. So it's quite an interesting thing, because in gynae cancer, you remove an organ and patient goes home 5 days later, maybe you get clear margins and you can stop worrying. I think it's fair to say if you're a kidney transplant surgeon, the patient starts passing urine following day, 5 days later, fit to go home, no further worries. Uterus transplant, the goal is to deliver a baby. It is not just to transplant the uterus. The sole goal is to have a baby. And so there's a long lag time before one can declare potential success.
I also, just to point out, I think that it's also, we make a huge stress on how much it's involved in this process, the number of clinics, the number of investigations, the number of biopsies. It's a huge undertaking, and that's they all know it, but even when you have to experience
You're
that,
living it.
it's slightly different. So it's paramount that patients are close by, and I would say that, preferably during the whole life of this transplant, that they need to be close to us to prevent any complications, or if anything was to happen, then people that know how to help them are close by.
Okay, yeah, that again isn't something that's immediately obvious, really, that you need to be geographically nearby. Okay.
And as Isabel just pointed out, there are the way that we monitor the state of the uterus is by taking biopsies from the cervix.
Yeah.
And whilst the cervix has, the uterus has no nerve supply, so the actual biopsy of the cervix itself per se isn't painful. Quite often there's narrowing of the vagina, and that can be quite distressing for patients. There's no doubt.
That's interesting. Okay, so we know that, for example, standard, straightforward IVF, we know that it can be psychologically demanding, really demanding. It can put a strain on the individual. It can put a strain on relationships as well. I imagine that this so much more so, because it already involves IVF as well as the transplant and the whole thing. What kind of support is available in that regard? I'm assuming that there's psychological support as part of the whole package, if you like. Is that correct?
Yeah, absolutely. There's psychological support from the London end, from somebody who was specialising on fertility stuff, and then there's transplant psychologist at the Oxford end,
Okay.
taking it from that aspect. And I think one of the vital things to say is, as people go through this process, that there are some people it is for them and it's something they really want, and there are other people who say this is not for us and we're not going to do this. And that in itself is important, because people close off avenues. Because I mean, as you know, you've got three options: adoption, surrogacy, or transplant. If you're Muslim or Orthodox Jewish, you can't do surrogacy, so they're down to two options. But it doesn't mean to say that what we're offering is the right option for everybody, because it isn't.
Yeah.
And a lot of people hear the whole story and they say thanks, but no thanks. But to me, that's actually that's a successful process for them as well.
Of course, the other option is that not everybody wants to have a child, and some people may want to start thinking that that's what they want and decide not to, which again is an absolutely fine option. People, it's giving women choices. I think is what we are doing, is
absolutely
presenting everything that is out there and how. And if we could help some women to make those choices, that's really what we've always been about. It's not about have a transplant, have a child. No, this is what we can offer. This is what is best for you, your partner, and your family, and your extended family.
Yeah, it's all about clear, thorough, open, transparent, honest counseling of all the choices, and then the choice is yours. Yeah, and that's so important in every field of medicine. So if I were a patient who would perhaps benefit from a uterine transplant, how exactly would I go about that if I lived somewhere else out of your radius?
Well, no, we're very happy to accept referrals from all around the country. So usually the referrals come originally to letters, emails are sent to Hammersmith House. And we've got a new website which will be up and running within the next 4 weeks, and all the various contact details are on there. So letters emailed over, and patients booked into clinic, and the clinic runs on a Friday. We do a lot of consultations in the first instance over the telephone. In fact, the vast majority of our initial consultations are over the phone, because there are people coming from the length and breadth of the UK. And it's not fair to bring people to London for that first visit, because quite a lot of people immediately decide this is not for them once they hear or we realise that they've got preclusions. Once we've done that, those initial telephone consultations, that's when we start bringing people up, and they have one. They come, and they're usually in West London for the whole day, and we try to tie together an MRI scan, and they'll have the blood's all done and all that stuff, and then the next consultation may be face to face or by telephone to go through all those results, and things progress like that.
Okay. I would be really happy to put a link to your website on the show notes for this podcast, so that anyone who's watching it can just click onto that and it takes you through to the
Yeah, cool.
website. So let me know when it's up and running. I'll just add it on. Thank you for that, because it's just the easier we make it for people, the better.
Yeah, absolutely. Yeah,
Okay.
Fantastic. I may say we're getting referrals direct from GPs as well as from centres doing MRKH like yourself.
Great, fantastic.
It's the occasional patient that has contacted us directly.
Yeah, that's true.
People that had heard about the program, and they just got in touch directly.
Fantastic. So my last question to you both in turn is, I'll start with you, Richard. What would you like to say to women who are considering the option of having a uterine transplant?
Ooh, that's a really good question, isn't it? I think information is power for patients, and the more information that a woman has, the more able she is to make an appropriate decision which is right for her.
Yeah.
And we are very happy to see people who are interested but unsure. That's in fact the majority of patients. And we're happy to see them and to help guide them through this process. And for some, it will prove to be the right thing, and for others, it will prove not to be the right thing. And that's absolutely fine. That would be my message.
Isabel?
I think I actually, I wish I went first, right? Because he just copies what I'm thinking. We are here to support patients and to help them get to the decision that is best for them, what is actually best for them. And at every point, at any point, if people changes their mind through the whole journey, nobody will judge them. We are here to support them. And it's absolutely fine to think that there are other options that are better than them. Not that them, that us, the option of a transplant, whatever is best for. I prefer patients that are fully committed and really, really know what they're getting themselves into than somebody that thinks, maybe I go along with that. No, there's a lot of it involved. So we want patients to be happy and to understand what they're getting themselves into.
Okay, well, I think it always helps that people kind of not only know kind of what they're getting into, but they have an idea of whom they're going to be looked after by. And I have to say, you are both so delightful to talk to. You are both so down to earth for two people who have achieved such tremendous things, so approachable. So I'm sure that in itself will encourage patients to come along and have the conversation with you. I've spent many years as a pediatric and adolescent gynecologist telling patients that, there'll be a light at the end of the tunnel. There's a lot of research going into uterine transplantation, and one day it will become a reality. Because I've been running the service for too many years, I won't mention how many. And I just want to personally thank you both for making this a reality for patients in the United Kingdom, that having uterine transplant is an option for them. Because my patients are delighted, I'm delighted for them. And yeah, even if they decide it's not right for them and don't go through with it, at least they have the option and they can get the information and make the decision that's right for them. So thank you so much for that. And also thank you for agreeing to come on to my show, because it's been a delight. It's been so informative, also entertaining. So thank you so much. And I'm sure it will help many, many women, not just in the UK, but internationally as well, to have this valuable information. Thank you so much.
Thank
Thank
you
you.
very much for the invitation.
Thank you for having us on. Thank you.